virus infection. And we can notice the microcephaly malformations and the hypomyelination. You can see the white matrix bright and the temporal. These are all typical manifestations of the cytomegalovirus virus infection. Toxoplasmosis, the chorioretinitis is the prime manifestation, and the parenchymal calcifications and the parenchymal destructive lesions, tissue loss. These are all the manifestations of congenital plasmosis. Congenital rubella syndrome, where white matrix hypodense and the basal ganglia calcifications. HIV also you should think whenever you are seeing extensive calcifications in the basal ganglia, apart from common hypoxic ischemic brain hemorrhage and metabolic abnormalities. Congenital herpes, it is type 2 virus, and it is a perinatal infection, and the typical manifest is not like type 1, where you will have limbic system involvement. Here, the involvement is in the brain parenchyma, cortex frontotemporal, and as well as the parietal lesions will be there. Diffusion restriction, and they will go for significant volume loss and calcification. These are all the typical manifestations of neonatal herpes. So this is what we covered is the congenital. Coming to acute. Acute meningitis, we will start with pyogenic. Is it meningitis is the radiological diagnosis? No. It is the clinical diagnosis, and the CSF is the confirmation. What is the role of radiologist? Role of radiologist to identify the complications like hydrocephalus, ventriculitis, cerebritis, effusion, emphoemas, infarcts, etc. And we have to find out the source. Is it mastitis responsible? Is it sinusitis is responsible? Or whether it is any skull-based defects, CSF rhino is responsible for the meningitis. And meningitis by means it is inflammation of the left meninges, pyometric membrane. Infants will have different etiology, E. coli and Listeria, and the group is streptococcal. Younger children it is H. influenza and streptococcal pneumonia and Neisseria meningitis. In adults it is streptococcal pneumonia and Neisseria meningitis. CT may be negative. Sometimes we may get effacement of basal systems as well as enhancing exudates. And typical appearance in MR is we will have in flying study we will have bright signals in flare sequences, so-called MRI equation, and the complications can appreciate. This young child, 2 years old, presenting with fever, meningitis, altered sensorium, classical nerve stiffness. The reference is to rule out meningitis. You can see the flare subarachnoid spaces in left side, which is absolutely normal. Whether you can able to appreciate anything over here, they are effaced, and you can not able to appreciate the low signal within the CSF, and they are filled with some bright signals. After giving contrast, beautiful, you can able to see the exudates. And you can see the enhancement of the left meninges over here, and this is typical appearance of the subdural emphysema as well as effusion. And you can see that here in this case, pachy also involved. You can see the involvement of the pachy also. And the subdural effusion, you can able to see the subdural effusion. So these are very classical. Please carefully look for subarachnoid spaces. It is very important. Cranial means you should look for spinal also. It is a craniospinal meningitis. You can see the brain exudates are there, subarachnoid spaces are involved, bright signal lesions, and spine also conus medullaris and cardiac infarction. It's a craniospinal meningitis, arachnoiditis. So always please screen the spine also whenever you are referring for this. Is typical manifestation of hydrocephalus. This is the complication. You can see the exudates in the basal systems presenting as hydrocephalus. And choroid fasciitis and intraventricular abscess, you can see the diffusion restricting lesion, and it is typical appearance of enlargement as well as enhancing choroid plexus. And whenever it ruptured into the ventricular system, it will present as ventriculitis or ependymitis. You can see the full-blown manifestation of the ventriculitis, sediment fluid level hydrocephalus. This is very dangerous when the patient needs immediate stenting. Coming to the abscess. Abscess, there are 4 stages: acute cerebritis, late cerebritis, early capsule, and late capsule. Acute cerebritis, it is very difficult to appreciate. Only it will manifest as white matter edema. And whenever going for capsule, few important things you should. Please do SWI, please do the perfusion. This is 2 things very important, always I will say. If you are not having contrast, at least you should do ACL. Light bulb diffusion restriction and titulated central bright signal, and the flare, the classical flare or SWI classical continuous dual ring sign and marginal enhancement, unless otherwise proved it is pyogenic abscess. It is light bulb diffusion restriction and attenuated central bright signal, marginal low signal rim, and a flare or SWI dual rim sign, which is continuous dual rim sign, and a marginal enhancement, unless otherwise proved it is pyogenic, and this is full manifestation. You can see the dual rim sign. The word is very important, the continuous dual rim sign in flare or SWI. And it is light bulb diffusion restriction, marginal enhancement. It is typical appearance of pyogenic. And you should find out the source. Is it mastoid responsible? Here it is acute suppurative erosion of the tegment tympani entering into the brain parenchyma. Here it is frontal osteomyelitis entering into the brain parenchyma. It is the skull base defect, it is cribriform plate defect presenting as meningitis. And it is tetralogy of Fallot, the child presenting as cerebral abscess and seizures. So please write on bronchiectasis. These are the things you should always think, immediately screen the rest of the places to find out the cause. This patient presented with the 5th and 6th cranial nerve. We can able to appreciate the enhancing lesion in paracellular region. You can see the paracellular Meckel scale along the 5th nerve, the lesion is coming. But the source, if we are carefully seeing, it is the mastoiditis and the apical petrositis. Petrous epicytis as well as mastoiditis. And involvement of 5th and 6th cranial nerves, it is Gradenigo's syndrome. Whenever you are seeing hyperintense CSF in flare, so-called MRIV voicing, what are the causes? Is it only meningitis responsible? No. You can get it in subarachnoid hemorrhages, you may get it in CSF metastasis, and if the patient is in hyperbaric oxygen, if the patient is having prominent vessels because of stroke, because of moyamia, because of leptomeningeal angiomatosis, all these things, rare but not ruptured dermoid cyst also can give. If you gadolinium in CSF also, renal failure patient, this is very important. Most of the CKD patients, if you are going to screen, the flare will be bright. This is also, you should keep it in your mind. This is the patient presenting with the severe headache, See the subarachnoid spaces, all subarachnoid spaces bright. This is typical event. So immediately the diffusion will tell what is happening over here. The diffusion restriction, subdural emphysema as well as epidural emphysema. And contrast beautifully demonstrating the leptomeningeal angiomatosis. You can see the dural venous sinus thrombosis. Also, you can see the emphysema. So all typical manifestations of meningitis. So MRIV voicing means first you should rule out leptomeningeal meningitis and all these complications. This patient, thunderclap headache, you can able to appreciate the bihemispheric level, you can see the bright signal. That means what you are suspicious, strong suspicion. You can see all basal systems are filled with bright white. And you can see the aneurysm in the right ventricle artery. It's typical appearance of the subarachnoid leak responsible for MRIV voicing. This patient, you see the subarachnoid spaces over here, see the subarachnoid spaces over here, that is positive. You can see the MRI voicing is positive. But see the cortical, here the cortical veins are deficient. So some vessels are seen over there. So it is a leptomeningeal angiomatosis. You can able to nicely appreciate that. You can see the calcifications in SW, you can see the enhancement leptomeningeal angiomatosis for hyperthesis but responsible for MRI voicing positive. Ruptured dermoid cyst, you can see the dermoid cyst over here ruptured, and you can see the subarachnoid spaces showing the bright signals. So always you should think over these things. And whenever you are doing CKD patients, they will be also having bright signals in the CS. Emphysema, it may be subdural emphysema or extradural emphysema. In infants and young children, meningitis is the common cause. In older children, adults, it is the sinusitis and osteomastoiditis. This young boy presenting as abscess in the preseptal compartment of the orbit, severe headache, neck stiffness, and you can able to appreciate the typical appearance of meningitis in the sphenoepimetal sinuses. Orbit large preseptal abscess is there. Brain, we can able to appreciate the epidural emphysema, the classical biconvex appearance and focal cerebritis. It may cross the midline. This is typical appearance. And here we can able to appreciate there is a, you can say, semilunar shape. Subdural emphysema, and you can see a subdural emphysema will not cross the midline. It will go along the shape. This typical appearance of parapulse in subdural emphysema. You can see the venous thrombosis also. The source is from mastoid. You can see that as it is the source. This boy presented with the right side hemiparesis, pre and postseptal cellulitis. We can able to appreciate the extensive pre and postseptal cellulitis, cavernous sinus thrombosis, vasculitis of the ICS plus lenticulosteroid branches presenting as infarct, large epidural emphysema. You can see the enhancing pecas plus leptomeninges over here. This is all very classical manifestation, but the source is a small fruncle in the nose produced all these nonsenses over here. So you should always think about these things. Up to now we have covered bacterial. Now coming to the viral. Viral, please think over one important herpes encephalitis. Herpes encephalitis in adult is because of HSV1. In children is because of HSV2. And HSV7 is the one which is a major cause for morbidity in lung transplant individuals. Epstein-Barr virus and HHV8, they are having strong oncogenic potential. If you are thinking of herpes, it is because of reactivation of latent virus in trigeminal ganglion, limbic system involvement. There are diffusion restriction lesion, bihemispheric involvement, and sequential asymmetry. One hemisphere will be affected first and it will be more, opposite hemisphere will be less. Involvement of insular cortex, cingulate gyrus, basal, it is basifrontal region, and sparing of the basal ganglia. This is one important. So diffusion restriction, sequential bilaterality, temporal lobe involvement, mesial temporal, insular cortex, cingulate gyrus, sparing of the basal ganglia. These are very classical manifestation of herpes encephalitis. Patient will be having headache, seizures, altered sensorium. You should think of herpes encephalitis. And other encephalitis, it is varicella zoster, Epstein-Barr virus, West Nile rabies, influenza associated. If you are suspecting chickenpox or varicella zoster encephalitis, brainstem and cerebellar involvement is very characteristic involvement. And one important condition, so-called MERS. What is this MERS? Mild encephalitis with reversible splenium of corpus callosum lesions. Whenever you are having diffusion restriction in the splenium of corpus callosum, apart from routine thinking like Machia Fava Pigeonami, post-ictal state, or some form of withdrawal fits, all these things will produce. Apart from that, whenever patient is having fever, little bit altered sensorium, you will have splenium of corpus callosum lesion and periventricular diffusion restriction. You should think of influenza also. It is a MERS, mild encephalitis, reversible splenium of corpus callosum lesion. Sometimes necrotizing encephalopathy also can come. Will be there. This is one of the features. You can see the acute necrotizing viral encephalitis because of influenza. So two spectrum of diseases. And if you are seeing Japanese encephalitis, it is bithalamic involvement. Classical appearance of bithalamic involvement in Japanese encephalitis. So up to now, you have seen herpes, you have seen Japanese encephalitis, chickenpox encephalitis, and influenza encephalitis. They are all acute. What are the chronic encephalitis? Chronic encephalitis, three main diseases: subacute sclerosing panencephalitis after measles infection reactivation of 3 to 4 years. And Rasmussen's encephalitis, because it will be manifesting as epilepsia partialis continua. That is one thing. CJD, this is the third one you should think. This patient 3 years back had measles, with this altered sensorium as well as slow onset dementing. It is typical. Initial days they will manifest as white matter hypodensities. Later they will go for atrophy, and the slow wave complexes in EEG is very classical, and the titer will be very positive. You can see the immunoglobulin G titer is positive for 1 in 625 dilutions. This is very classical of herpes. This is very classical of subacute sclerosing panencephalitis. Rasmussen's encephalitis, it is a chronic form manifesting as a seizures, progressive hemiplegia, psychomotor dissociation. You can able to see the unihemispheric atrophy. It is classical. Whenever you are having one hemispheric atrophy, is it Sturge-Weber? Is it Dyke-David affirmation? Is it Rasmussen's encephalitis? The clinical question will answer in the clinical examination. If the patient is having continuous epilepsia partialis, it is very classical manifestation of Rasmussen. The patient is having port veins in Sturge-Weber. And in Sturge-Weber, the cortex is anomaly. In Dyke-David affirmation, it is arterial anomaly. It is MCA is occluded. That's why this is too important prime manifestation. So the angio will give the answer. What is responsible for hemispheric atrophy? CJD is a slow viral prion disease. It may be familial or sporadic, or it may be iatrogenic. And one important sign is pulvinar sign as well as ribbon sign. These are the two manifestations. The clinical manifestations are dementia myoclonus. The word is very, very important. They will manifest as myoclonic gait disturbances, slow onset progressive dementia. EEG, here it is the short wave complexes and raised protein D3 protein. This is classical appearance. Whenever you are having diffusion restriction in the basal ganglia, please carefully look for the thalamus also. The reverse artistic sign will be there. And one important thing which I told, ribbons, and you can see the parotoccipital cortex. This is typical manifestation of ribbons, and you can see the thalamic involvement. These are all very classical manifestations of CJD. Coming to common tubercular, fungal, parasitic, and other infections. Tuberculosis can manifest as meningitis, caseating or non-caseating tuberculomas or abscesses. This one agent will have neurotropic. It may manifest as ventriculitis, it may manifest as opticochiasmic arachnoiditis, it may manifest as cerebellar tuberculosis, hydrocephalus, all these things. Here is the one, you can see the CP angle systems engulfing the 5th, 7th, 8th as well as along with the 3rd cranial nerve, so it may present as cranial nerve palsies. Opticochiasmic arachnoiditis will present as dreaded complication. Patient may lose vision. You should start with steroid immediately. And you can see the leptomeningeal enhancement typically exudates in the basal system, presenting as hydrocephalus. It may involve the vessel, it may present as hemiplegia. So, and in neurotropic as well as angiotrophic agent, this is the manifestation of various phases. It is classical appearance of multiple granulomas in the opticochiasmic hypothalamic involvement will be. So the presentation is they will lose the vision. This is one thing you should always keep in mind. Regarding caseating tuberculomas, flare T2 low signal. The word is very important. Central low signal in T2 and there will be isointense in T1, a typical lipid peak and absence of rest of metabolites. This is very classical manifestation. You can see the low signal center. This is caseating tuberculosis. Whenever low signal center, this is caseating tuberculosis, ring enhancement, and you can see the lipid peak and absence of rest of metabolites. It may involve the bone also. You can see the temporal bone is involved and you can see the cortex is involved and the low signal is very classical manifestation in T2 and only lipid peak is there, the rest of metabolites. So this is the manifestation of TB osteomyelitis, cerebritis as well as and leptomeningitis. It may involve the spinal cord also. This young child presenting with paraparesis and a lesion in the spinal cord, you can beautifully appreciate the lesion in the lung parenchyma. You can see the lymph nodes also, you can see the neck nodes also. It's very classical manifestation of a disseminated TB. Fungal lesions, it can come in immunocompromised as well as compromised people. And whenever you are suspecting immunocompromised, it may be Candida, Streptococcus pyogenes. In normal as well as immunocompromised, histoplasmosis, plasmacytosis, and aspergillosis oxidative. 500 blood sugar, this patient presenting with frozen globe on left side, total ophthalmoplegia. You can see the right side, all extra hormones are absolutely normal. Left side, you can see the doses and 346 frozen globe. That means you should think of mucormycosis. There is an infection with hyperdense material in the ethmoid sinus, gone to the orbit. You can see the cavernous sinus filling defect, dilated SOV over here, edematous extraocular muscles, dirty fat. That means pre and post septal cellulitis, cavernous sinus thrombosis, responsible for this. This is typical appearance of mucormycosis. And fungal granuloma, you can see the sphenoethmoidal granuloma extending into the cavernous sinus, responsible for fungal sinusitis as well, cavernous sinus extensions. Bilateral basal ganglia, dilated VR space-like appearance. It is typical of the gelatinous cyst of cryptococcus neoformans. It is so-called dorylomas. This is typical manifestation. They will not enhance with contrast. Multiple dilated VR spaces-like appearance, basal ganglia involvement. It is cryptococcomas. Neurocysticercosis. There are 4 stages of neurocysticercosis: colloidal, vesicular, granular, nodular, and nodular calcium. How to? One is live cyst. Typical live cyst, there may not be any edema at all. Marginal scolex is typical appearance. You can see the marginal scolex, no edema. It is live stage. When it is going for dying, the edema will start and you can see the marginal enhancement will be there and adjacent leptomeningeal changes will be there. That means it is dying, classical of a colloidal vesicular stage of cysticercosis. When it is healing, it will manifest as a granulomatous lesion. You can see the granular nodular stage. When it is dormant, dead, it will manifest as only punctate calcification. There are 4 stages. And sometimes combination of all can come. You can see the live, you can see the dying, you can see the dead, all combination can come. You can see the temporal muscle involved, temporalis muscle is showing, and you can see the paraspinal muscles, so all these things. When you are giving treatment, sometimes all this will go for immediate dying stage. The presentation may be in encephalitis. You can see the multiple lesions, extensive edema, they may manifest as encephalitis, cysticercosis encephalitis. Intraventricular cysticercosis also you should think of. This patient presenting with acute hydrocephalus, you can see the fourth ventricular cysticercosis, you can see the lateral ventricular cysticercosis presenting as a sudden onset hydrocephalus. Coming to amoebiasis, there are two manifestations of amoeba. Itself, it is HIV-1. Two manifestations. It is HIV-associated neurocognitive disorder, so-called and AIDS dementia complex. How to differentiate HIV encephalopathy from PM? It is diffuse atrophy and periventricular white matter hypodensity. This is typical appearance. Periventricular white matter hypodensity, given metal isointense signals, no enhancement. You can see that another case, classical periventricular hyperintense signals and bilateral involvement, symmetrical involvement, not enhancing with contrast. Typical appearance of HIV encephalopathy. PML, it is because of JC polyomavirus reactivation and it is asymmetric and subcortical involvement. You can see that asymmetric subcortical involvement is very classical appearance of PML. PML can involve posterior fossa, PML can involve the middle cerebral peduncle, and it is subcortical involvement, no enhancement. This is very classical appearance of PML. Opportunistic infection, toxo, cryptococcal, CME, and TB. How to localize toxoplasmosis? Whenever immunocompromised patient coming with seizures or sudden onset altered vision, you should carefully look for the lesion. If the lesion is in basal ganglia, if the lesion is in subcortical location, if the lesion is having central low signal and eccentric target sign, the word is very important, eccentric target sign, disproportionate perilesional edema, low CBV, PET negative, it is toxoplasmosis. So low signal basal ganglia lesion, subcortical lesion, hemorrhagic nature and eccentric target sign and low CBV, PET negative, it is very typical appearance of toxoplasmosis. And what are the other manifestations of HIV? The marrow may be very low. If you are suspecting low marrow, you should think of, apart from renal failure, apart from anemia, myelofibrosis, please carefully think of HIV also and look for adenide. Always look for adenide. Whenever you are having enlarged adenide with the intra-adenide cystic areas and multiple lymphoepithelial cysts also, please look for all these things. They are very important. And multiple lymph nodes and adenide hypertrophy. These are all the manifestations of HIV you should think about. And the immune reconstitution inflammatory response is commonly seen after HAART therapy. It may be unmasking or paradoxical. After giving treatment, the infection will get worse. This patient having tubercular infection worsening after HAART treatment, you can see the intracranial tuberculoma, you can see the cerebral as well as the lung tuberculosis also. And one important manifestation of HIV is patients lymphomas plus Kaposi sarcoma. The CNS lymphoma is seen as a hyperdense lesion in NECT, involvement of the basal ganglia as well as corpus callosum, and the homogeneous enhancement, diffusion restricting lesions. You can see the periventricular diffusion restricting lesions in the fourth ventricle as well as you can see the involvement of basal ganglia. You should think of lymphoma also. You can see the typical appearance. Now, we may ask one question, how to differentiate HIV encephalopathy from PML? If you are having symmetric white matter involvement, periventricular and isointensity or not enhancing with contrast, you should think of HIV. Asymmetric involvement, subcortical white matter, paratoxical predominant may be seen in positives also. Hypointivan weighted, not enhancing, you should think of PML also. And toxoplasmosis versus lymphoma. The lesion of low signal in nature, subcortical involvement, and it will have eccentric target sign. This is very important, eccentric target sign, low CBV and cold infection, it is toxo. If you are having periventricular involvement, corpus callosal involvement, and high CBV, hyperdense in NECT, heart impact, it is the lymphoma. And final 2 minutes I will take. Whenever you are having ring lesion, the question they may ask, is it abscess, is it neoplasm? If it is abscess, is it pyogenic or fungal? Or what are the other causes of ring, like tuberculosis, cysticercosis, toxoplasmosis, tumefactive demyelination? Please use perfusion sequence and SWA also. I will show you how we can differentiate. Light bulb diffusion restriction and central low signal in T2 and flare SWA dual rim sign, continuous dual rim sign. It is, and marginal enhancement with contrast, it is pyogenic abscess. And if you are doing perfusion, it is low perfusion. It is infection means it is low perfusion. Neoplasm means it is high perfusion. And you can see the succinate peak, it is very classical. You can see the abscess, typical appearance. You can see the bulb, diffusion restriction, low ADC, marginal enhancement, and you can see the low CBV. It is pyogenic. But diffusion restriction can be seen with metastasis also. You can see the small cell malignancy with metastasis having diffusion restriction. But the CBV is increased. CBV is increased. This is one important thing, sir, to differentiate metastasis or neoplasm from. You can see the tumor, this GBM having this, but the vascularity, marginal vascularity is increased. So the CBV will help always, even though diffusion restriction, CBV will help. You can see the marginal, you can see the increased CBV. So always please think of CBV also. So to differentiate infection from neoplasm, the one important sequence is perfusion. So low CBV means it is infection, high CBV means it is neoplasm. Now you may ask, how to differentiate pyogenic from fungal? Fungal means it is hemorrhagic nature. You can see the diffusion restriction light bulb, it is pyogenic, and you can see the continuous dual rinsing. It is very important thing for pyogenic. And it is broken ring. You can see the broken, it is very classical. And the diffusion restriction may not be full. It is a light bulb in pyogenic. It is not full in fungal. Fungal will have eccentric diffusion restriction and irregular rim, dual rim sign. Here it is continuous dual. So these are the points to differentiate fungal from pyogenic. Tuberculoma, caseating, tituated fluorescental low signal, that is very characteristic, and the lipid peak will be there. Toxoplasmosis, central low signal, eccentric target sign, hemorrhagic in nature, low CBV, PET negative. These are all very classical features of toxoplasmosis. Demyelination, it is stim-effective demyelination. You can see the inner surface will alone enhance, and broken ring will be seen in the cortical surface. This is incomplete ring enhancement. This is classical of demyelination. Thank you.